Thanks for the invitation. Switching gears now to the other end of the spectrum of fetal intervention. This is a hot topic right now in our group, and so wanted to take the opportunity to share with you. So I'll present a case of a patient that we take care of who was born anephric. We'll briefly review embryology, brief enough so nobody falls asleep, and the role of amniotic fluid. And the recent published data on the outcomes of children born with bilateral renal agenesis, whose mothers underwent amnio infusion, and hope to have discussion about what you all think about this therapy. So AT is our patient. She is currently 3 years old. She was born at 32 weeks gestation. She was born with bilateral renal agenesis. And at birth, she weighed 1630 grams. And when she was born, she was noticed to have left arm and leg stiffness. And 3 months into her life, she was found to have encephalomalacia and a posterior cerebral artery stroke. She presented with seizures. And throughout her young life, she has seen many different modalities of renal replacement therapies. She's required Aqueduct CRT with the Carpe Diem, and then Prismaflex, and of course peritoneal dialysis. And because of complications, she's interchanged between the different modalities, which has resulted in lots of issues with her vasculature. So as we worked her up for a kidney transplant, we found occlusion of her inferior vena cava below the level of her hepatic veins, with formation of perivertebral collaterals on the right side and development of a replaced azygous and hemiazygous system on the left side. And that resulted in not being able to use mom's kidney, who she was worked up for and approved initially as a donor, and we'll have to wait for a pediatric-sized kidney. The other complications for our patient was we were trying to figure out how we will drain the transplanted kidney, and many of our patients' families are electing to do bladder cycling and preparation to insert the ureter into the bladder. And for our patient, it failed because the bladder was too far from the pelvic bone, and the caliber of the bladder was actually smaller than the urethra, and so the option will be ureterostomy at the time of transplant. With all this, in clinic, she is extremely charismatic and engaging, communicative, and without hesitation, the parents state that they would do this again, and that she brings a lot of joy to their family. So, switching gears. The embryologically, the kidney development starts pretty early, even before the 5th week, with the pronephros. But the pronephros is a vestigial organ, a remnant that likely allowed us to go from a fish to a philosopher. But from the pronephros, you have the mesonephros, which leads to the mesonephric duct, which attaches to the cloaca, which will be the early bladder formation. And from the mesonephric duct, you have the ureteric bud. And the ureteric bud is encased by the mesonephric, the metanephric mass, and there's a bidirectional signaling that allows the final kidney to be formed by 9 weeks. So the ureteric bud will form up until the collecting ducts, and the metanephric mass will provide the glomeruli and the tubules. And this slide is not for you to read the specifics, but it's just to demonstrate how elegant this process is and how many genes are sort of associated. And there's genes that have to come on at the right time and turn off at the right time for the final kidney to be formed. And it's quite amazing. And each kidney independently goes through this. So you can imagine if something goes wrong in the process, you can have various anatomical anomalies that lead to the congenital anomalies of the kidney urinary tract. The cloaca is separate in itself, but issues with the bladder and the prostate, of course, always also lead to complications for the kidneys. So the function of the amniotic fluid, it's quite important. It allows space for the fetus to grow symmetrically, prevents adhesion to the amnion, allows movement, and it's a source of oral fluids and growth factors such as EPO and GCSF. And it's important for lung and digestive tract development. Initially, the production is ultrafiltrated from the maternal plasma. And then the extracellular fluid that diffuses through the fetal skin until it keratinizes, and then the primary source of the amniotic fluid becomes the fetal urine, with a small percentage coming from the lungs. And so this is where we see, with the absence of renal function towards the second to third trimester, mothers will have oligo and hydramnios. And in that setting, the child no longer has the ability to move, no longer has the ability to grow symmetrically, and through development has stress throughout the body, which leads to abnormal development of the limbs. They often short, they often have contractures. The nose will be flat, the eyes will be spread apart and with low set ears, just because of the lack of the amniotic fluid, also known as the Potter syndrome or Potter sequence. And when we see these families in prenatal consultation, the main message that we have is lungs determine survivability. And with the absence of the amniotic fluid, what it causes is depressurization of the fetal airway system, which leads to significant, often lethal pulmonary hypoplasia, and children often die either in utero or shortly after birth. Over time, there was experience from monochorionic, monoamniotic twins, so those that shared the amniotic fluid, where the twins were discordant, with one being anephric and the other having normal kidney development, and that resulted in adequate pulmonary development in both. And so no longer the child that was anephric did not have lethal pulmonary hypoplasia. So this observation sort of led to the hypothesis that maybe if you give serial amnio infusions, that you can protect the child from having pulmonary hypoplasia. So 1994 was the first case report of a child with renal agenesis, where the mother received 10 amnio infusions, and the child was born with no significant pulmonary hypoplasia. Unfortunately, the neonate died at 23 days of life due to unsuccessful dialysis. Multiple attempts in between, but fast forward to 2019, there was a publication of 2 infants that were born with bilateral renal agenesis, who were bridged by chronic peritoneal dialysis to kidney transplantation. So they had received amnio infusions. They did not have significant pulmonary hypoplasia allowed them to survive, and were able to grow enough to place a peritoneal dialysis catheter, allowing them to grow to receive kidney transplant. And the first patient was quite famous and is well recorded with multiple interviews throughout. And so the parents that you see, this is Jamie Herrera Butler, who was a Washington Congresswoman. She was also famous for voting to impeach Trump after the Capitol riots, and then, of course, we know she was not reelected. And here is the first picture with Ms. Butler, her husband, and their daughter, Abigail. And she was the first patient to have survived with the amnio infusions to kidney transplantation. And this is on the right is a picture of them in 2017. At that time, she had received a kidney transplant from her father, and the parents also had a healthy son as well. And she has continued to do well. With this, especially with all the media coverage that was there were more parents that were reaching out to see if this was an option for them. And there was various centers throughout the country that were offering this with different levels of support from the pediatric side to be able to do the interventions. And different consultation of what the risk factors were. We've taken care of, I think, at this point, 4 children who were born with bilateral renal agenesis or required amnio infusions for various reasons. And some families were told that the hardest thing is to delivery, and then everything else should get easier, which we find not to be the case. So in this setting, the NIH and the subdivision within there, as noted here, sponsored a workshop to define knowledge gaps related to anhydramnios secondary to congenital anomalies of the kidney urinary tract, including bilateral renal agenesis. And they concluded that safety and efficacy of amnio infusion should be studied via IRB-approved research. And from that came the formation of the renal anhydramnios fetal therapy trial, or called the RAFT trial. So in their design, it was split into the intervention group that would receive the amnio infusions, and the expectant management group who chose not to receive the amnio infusions. And it was a parallel, non-comparative study of the congenital bilateral renal agenesis, and FRF, meaning fetal renal failure. So it had some renal tissue, like multidysplastic kidneys or obstructive uropathy that led to the kidney failure. The inclusion was maternal age greater than 18 years, singleton gestation, completed multidisciplinary consultation, which included pediatric transplant surgeons, general surgeons, pediatric nephrologists, fetal, maternal interventionalist, a geneticist, and a social worker. They had to have the ability to begin amnio infusions by 26 weeks at one of the 9 RAFT sites throughout the country. And this was important because we will see the numbers, but 94% of the families that were enrolled in the study were white, and which speaks to the fact that you needed to have good enough socioeconomic means and support to be able to move your family to that region. And not just for the amnio infusions, the delivery and postnatal care had to be at the RAFT trial until discharge home on long-term dialysis, except for if you were doing the expectant management, then you could deliver closer to home. Exclusions, any extrarenal congenital anomalies, which may preclude placement of a dialysis catheter, pathogenic findings on karyotype marker array around the same line, and restricted contraindications to amnio infusions itself. And these were the 9 sites. So as you see, pretty various throughout the countries, consolidated in the Northeast corridor and in California. Here at the University of Washington at that time, our OB group did not feel that they would want to provide amnio infusions as a thought that the risks were too high, and it was just experimental. So the arm of the bilateral renal agenesis group was stopped early. The fetal renal failure group study is still undergoing. And it was stopped early, one, because the efficacy of the primary intervention, which I'll get into more in the next slide, and also concern about neonatal morbidity and mortality beyond the primary endpoint. The DSMB consisted of 3 maternal fetal specialists, one from Canada, one biostatistician, and one ethicist. There were no nephrologists as part of this group. So there was a recent publication of their findings in JAMA, and the objective was to assess neonatal outcomes of serial amnio infusions initiated before 26 weeks gestation to mitigate lethal pulmonary hypoplasia. So really, this is from the perspective of the interventionalist, saying that will the amnio infusions lead to appropriate lung development and stave off pulmonary hypoplasia that leads to death. And so therefore, the primary outcome was postnatal survival to 14 days of life, meaning the lungs developed well enough to survive to that length of time, and that they grew big enough to have a dialysis catheter placed. So at the time of the publications, there were 37 total enrolled patients, maternal fetal pairs. 33 chose serial amnio infusions, and 4 chose expectant management. The highlighted are the bilateral renal agenesis group. And so this was a prospective, non-randomized clinical trial, again, conducted in the 9 United States fetal therapy centers from December 2018 to July 2022. So in the bilateral renal agenesis group, in the intervention group, there were 18. All 18 underwent serial amnio infusions, and 17 had delivered at a RAF center and were able to be assessed for the primary outcome. There were 3 in the expectant management. All 3 had routine prenatal care, and they delivered at a RAF center or locally. So if you weren't getting the interventions of amnio infusions, that you could deliver your child locally. So looking more closely at the 3 that had expectant managements, all 3 had live births, and all 3 died within 12 hours from severe pulmonary hypoplasia, as expected. The 1 fetal demise in the intervention group died at around 24 weeks from preterm premature rupture of membranes after the second amnio infusion, which is a known risk. So 94% did deliver. Of the 17 that had live births, 14 survived to the primary outcome. So 82% survived to 14 days and had a placement of a dialysis catheter. And the factors that increase the chance of survival, or suggested more increased survivability, total number of amnio infusions. So if you didn't have that many complications, you were able to get more amnio infusions. So more survivals had that. Time from first amnio infusion to rupture of membrane, so less complications, again, would favor survivability. And gestational age, so the older the child, all children were born premature, but the further along in gestation improved your survivability, and the bigger you were, improved survivability. If you remember, our patient that we presented weighed 1630 grams, so right in between the survivors and the non-survivors. So looking more closely at the 14 that met the primary outcome, only 6 survived to discharge from the hospital, so about 35%, and the median age at discharge was 24 weeks, or about 6 months. Of those that went home, 2 had subsequent deaths, 1 at 2 years of age from infectious complications, and the second at 4 months of age of cardiac complications, the 2 most common causes of mortality in our dialysis patient population. And 4 had long-term survivors, were the long-term survivors. Of the 6, 50% had neurologic complications of stroke, similar to our patient with presentations of seizures. So how do we look at that 22% survival with current data? So this is data from the United States Renal Data System, and the patient population is the age of initiation of dialysis, and so less than 1 is less than 1 month of age, and has with the various time periods. And so to really for us to compare, the closest is from the 2000 to 2014 of infants that started dialysis as less than 1 month of age. It's not a true comparison because these are patients who were healthy enough to survive hospital discharge. So it only included patients who survived the initial hospitalizations. And so you have a survival bias here. So if we compare this, then the RAFT had 4 out of 6 post-discharge survival. And so at 1 year, it would be 83% compared to 86. And at 5 years, 66 versus 74. Of course, a lot more patients, 372 in the USRDS group versus only 6 in the RAP trial. Maybe a slightly better comparison was a study by Dr. Clays from 52 hospitals with the Pediatric Health Information System, where they looked at overall survival to discharge from their primary hospitalization. So these are children who had kidney failure from birth, who started dialysis soon after birth, and of those who survived to discharge to the hospital. And overall survival was 76%. And so this is requiring dialysis that includes just renal failure for causes including and other than bilateral renal agenesis. And so compared to that group, 35% from the RAP trial had survived to discharge, so that's 6 out of the 18. The risk for mortality included requiring mechanical ventilation and increased mechanical ventilation. And so, again, our RAF patients would require more mechanical ventilation. Even though the pulmonary hypoplasia isn't lethal, they will still have some level of it. And the dialysis modality, if they were healthy enough to be transitioned straight to peritoneal dialysis, then they had increased survivability. If they needed other extracorporeal dialysis modalities like aquapheresis or carpe diem or through Prismaflex, then they had increased risk for mortality. So life outside the hospital. So this is what we are struggling with is all patients had significant hypotension. They did not have any renal tissue. And so the RAS system is non-existent. And we had to get comfortable with blood pressures, with systolics in the 60s for these patients. And so you can imagine going to the OR for various procedures under anesthesia becomes complex to manage them. And because of the significant hypotension, there's leads to neurologic issues, and many of these patients will have strokes, watershed infarcts because of the significant hypotension. Also, we don't know how they will, because of the early neurologic insults, what their growth and development will be. And so this is a bit too early to say. What the studies do tell us that the earlier, the younger you are, where you're struggling with chronic kidney disease or renal failure, you have learning disabilities, you have especially delays in executive function, ability to critically think, which also affects care as they grow older. And then finally, as in our patient, these children have never seen urine in their bladder. We don't even know if the bladder was formed properly. It could be, but post-transplant drainage of their kidney becomes an issue. And finally, the care of that child on dialysis requires a lot of sacrifices from the families themselves. Both parents cannot work. The attention given to other children and to other family members will be affected. And unlike this family presented here, many of our parents don't have the support of extended family members close by, and so they often are dealing with this on their own. And we also have single parents who are also trying to manage this as well. And I think we should talk about the moral injury from the provider side. You know, this is an ethically complex scenario. I think all of us would have different opinions, and all of our opinions would be true. But when presented with this child in our family, it is our obligation to help them. But as you have the child go through multiple procedures and multiple complications, you do feel the burden of asking yourself, are you causing harm to the child who's not really able to express their feelings? And you have to rely on the parents' wishes with that. So now what? You know, the study was stopped early, but you can look at it, I think, in one of two ways. You can say, you know, mortality prior was 100%, and now it's not, and we have hope. And this is sort of similar to the evolution of therapies for some of our other children who had trisomy 21 or trisomy 18, which was initially thought to be lethal. Then over time, there have been therapies that have been afforded, and now it would be unethical to abort a pregnancy of a child with trisomy 21. And I think because of this hope, there are going to be families that are going to choose amnion infusions. And I think there are going to be definitely centers throughout the country that will continue to offer this. But I think the main thing, what we should push for is appropriate counseling of the families. And now that we have families who sort of survived this, they should be part of the consultation as well. And included in the consultation is the receiving pediatric nephrologists at centers that may not be participating in these interventions, but will be caring for the family long term. I think they should have a seat at the table for the consultation. And all these maternal fetal pairs should be part of a study or registry. It's going to be hopefully rare, but much needs to be learned, especially of long-term complications that may arise later on, and the burden on healthcare and society. This will be my last slide. Will Durant was a historian and a philosopher in the 30s, studying civilizations, who said, to give life a meaning, one must have a purpose larger than self. And uniformly, the parents that have taken care of their life purpose is to care for their child who's on dialysis, and it has provided them with a lot of meaning from it, which is quite remarkable. So with that, I will stop and take questions and get your thoughts.
Thank you so much. Incredibly clinically and ethically complex situation. Thank you for that review. Questions for Raj?
This is just a logistics question, but how early in utero can you tell that a baby's anephric?
Yeah, usually they will start ultrasounds around 20 weeks. We'll do the anatomic ultrasounds. If there's oligo and hydramnios, sometimes they'll do an amnio infusion at that time to allow for better visualization. So usually anywhere between 16 to 20 weeks is reasonable to have an appropriate ultrasound to look for renal tissue.
You mentioned that, this counseling, that if you make it through pregnancy, you're
You're
smooth
golden.
there,
Yeah.
is not not necessarily the case. Gaoyan asks, particular question about transplant survival, but is there a point that you do think these patients are, going to do well, or some indication?
I think if they do survive to transplant, they receive a transplant, I think they'll do well. And that's what we've seen in the other populations that we take care of as well. If you're healthy enough to get to a transplant, after transplant, you tend to do well. They will, I think, given the issues of drainage and stuff, it will depend on what the family chooses. All these families also hope for as normal of a childhood for their children as possible, and to go to schooling with the ureterostomy sort of doesn't align with that goal. And so this is where bladder cycling and all that has come in. And so I think all those choices, we'll see how that impacts the health of the kidney. The ones that have received a kidney transplant, they continue to do very well, and their growth and development has improved dramatically, as we see with other children who get a kidney transplant.
It's good news for the adult nephrologists by the time they get to us.
Yeah.
Any last questions for Raj before we adjourn? I mean, I'd personally love to hear more about the kind of ethical issues and decision from UW not to, I think it was not your decision, it sounds like, but from obstetrics, not to offer this treatment. Maybe a bigger question.
I think now now they're starting to, and so I think we're, I think now they're thinking about it, or we may have already started, but at that time we didn't. Yeah. Great. Thank you, everyone.
Thank you so much. Thanks to all three of our speakers. Some excellent talks today. Everyone have a great sunny weekend. See the cherry blossoms, and we'll be back next week on Zoom. Bye now.